Thanks, Dr. Abdullah, for the kind introduction. Today, we will use those 2 hours the same way. There will be 3 theoretical lectures about diastolic function, strain, and RV function by me and my colleague, Dr. Shadi and Dr. Fadi. And then all of us will be divided into 3 teams, and we will rotate around the 3 machines, training on what we said. We will not say theoretical things. It will be applied, and you will be trained on. For long years, since the first cardiac cath, 1949, we thought that filling of the heart is passive due to pressure difference, and when the pressure is higher in one chamber, the valve will open and the heart will fill passively. Till 1980, when this paper came, and it could calculate the so-called tau, or the time constant of filling, and they could prove that filling is an active process and it is ATP consuming. So to deal with diastole, you have 3 processes. One of them is the passive stretch of the collagen mesh that entangles the myocardial fibrils. We have the relaxation of the myocardial fiber, which entails suction of blood, and we have the filling pressure. But in our daily practice, we focus on the filling pressure. And today, we will try to organize the way we think, so it will be steps how to evaluate primarily the filling pressure. Diastolic function is graded into normal, grade 1, grade 2 when the filling pressure of the atrium starts to be higher, and grade 3. And remember, to feel dyspneic, your mean left atrial pressure should exceed 24 millimeter mercury. So we have the normal pressure, when it is less than 15, then start to rise. This is grade 1, and then higher and higher, that grade 3. And I remind you, grade 3 is called restrictive, and it's either reversible or irreversible by doing a Valsalva to differentiate. Also, the tau is the cath counterpart, which is not done so frequently these days, but you should know the gold standard when you are in doubt, and it also increases in the elderly, in the dilated myopathies, in those with HFpEF, whatever the reason. Assessment of relaxation, which is also important, but we always overlook it, can be by deceleration time of the E. You know, the mitral valve, when you put the pulsed Doppler on the mitral valve, when it is widely open at the level of the tips, not the annulus, we see the deceleration time of the E prime amplitude, and IVRT, which we measure it by putting the cursor between the mitral and the aortic. It is 66 milliseconds plus or minus 33. So if it is prolonged, this is abnormal relaxation, and if it is short and less than 66, then this is a high filling pressure, and it helps in special situations. The mitral inflow and the annular velocity, we have to have a wider look for it. So if the E prime starts higher, when it goes down, this is the grade 1, and then starts to rise later, that rise goes more with high filling pressures. And remember, the E amplitude is proportional to the difference in pressure between the left atrium and the left ventricle. So the higher the pressure difference, the higher the E amplitude, and definitely the higher the filling pressure. So it is rising up. And contra to this is the E prime amplitude, which is looks how this is normal, and then we see it gets smaller, and usually the significant one is less than 7 millivolt per second, millimeter per second. So as LV filling increase, the mitral E amplitude, the pulsed Doppler and the tips of the mitral valve increase, the mitral E prime decrease, and the EE prime ratio increase. And this is a graph showing that with the increase of the EE prime, the wedge pressure goes up. So it is correlated, and there is some equations when you add 1.9 and multiplied by 1.24, and these equations makes assumptions or takes you from the estimation to the calculation and can deviate you from a little bit from the reality of the measurement. So better to rely on the ratio, and usually if the ratio is 15 or more, the filling pressure is, or the wedge pressure is above 20 millimeter mercury. Also, estimating the filling pressure, whether you have a systolic dysfunction or a normal function, means you have ejection fraction above 50 or below 50. When it is less than 8, it is normal. When it is more than 15, the filling pressure is high, and we have a gray zone when it is between 8 and 15, that's a gray zone where you have to use other tools. Also, the relationship between tissue Doppler-derived diastolic indices and age. By the time you get older, your E prime will become smaller, your A will go higher, and your EE prime ratio will go higher. Also, the left atrial volume index. Index means left atrial volume normalized to the body surface area, normally less than 34 ml per meter square body surface area. So by increasing the diastolic dysfunction, increasing filling pressure, the left atrial volume index will increase. Another issue, when you have a hypertrophied heart, is it simply hypertension or this is a case of HFpEF? Here you look to a lot of things. The one most impressive is the pulmonary artery systolic pressure, with the area under the curve is highest. Also the EE prime ratio, the left atrial volume index, the relative wall thickness. All these will be different to differentiate between heart failure with preserved ejection fraction in a hypertensive patient versus just patient who have remodeled his heart due to hypertension long-standing. So we start our real work. This is what we will train on. You have to memorize those four, because by using these four parameters, you will be able to judge this patient has a high filling pressure or not. The E prime velocity, should be more than 5 medially, the mitral, or more than 10 in the lateral. The EE prime ratio less than 14 when you average it. How to average it? You calculate mitral and lateral annulus, and you summate it and you divide it by 2. Or if you take the medial alone, should be less than 15. The TR velocity should be less than 2.8 meter per second. And the left atrial volume index should be less than 34 ml per square meter. This is very important because now we will start to train. So if the ejection fraction is normal, we start by the septal E velocity, E prime velocity more than 7, or lateral velocity more than 10. This is for the normal ejection fraction, and the other three are for everybody. So the average EE prime ratio less than 14 averaged, and for the medial is 15. TR velocity less than 2.8, and left atrial volume index less than 34. So if you have the three normal, this is a normal diastolic function. Diastolic function means normal filling pressure. We will now just skip the relaxation and skip the passive stretch. We are talking about filling pressure. This is the real life, everyday case you do in your lab. If you have 2 positive, 2 negative, this is an intermediate. We have to use other tools, and we'll tell you the other tools. And if the more than 3 abnormal, then we are talking about diastolic dysfunction. So let's see this case. A 71-year-old woman with a left atrial volume index 39, that is more than 34. Her EE prime ratio is less than 14. Her E prime is more than 7. And left atrial volume index is enlarged, and the TR is less than 2.8. This is the data we have. So this is, does she have a diastolic dysfunction? Does she have a high filling pressure? Well, it's not. The strain is normal. The other parameters are normal, and only one parameter is enlarged. So we don't take one parameter and say, oh, left atrium is enlarged, this is diastolic dysfunction. Because this is not the only reason for a left atrium to get enlarged. It could enlarge due to diastolic dysfunction, increased filling pressures, increased volume overload, athlete's heart, measurement error, and add one more, that's atrial fibrillation by itself can enlarge the atrium. So all these can enlarge the atrium. So just an enlarged atrium does not tell that there is high filling pressure. What about normal or grade 1 diastolic dysfunction? When you see this figure, the E is around 50, the A is 100, the EE prime is less than 0.8, so this is normal filling pressure. But the A amplitude is higher. This A amplitude could be grade 1, could be normal for age, and even this also, when the A is higher, it could be also high filling pressure if the A reverse of the pulmonary vein is 30 milliseconds or more in duration, more than the A. You will find me flooding you with a lot of numbers, but when you go home and you review this, it will be easy. But you should not stop at the point here. You should go home and go to your lab and practice here when you memorize. So this is what in the American guidelines and European the same. Patient with an ejection fraction more than 50, we look to the septal velocity. This is more characteristic of the normal systolic function, and those three, EE prime ratio, TR velocity, LA volume for both systolic dysfunction or normal systolic function. If you have more than 3 normal, that is normal filling. If you have more than 3 abnormal, this is increased filling. And you have 2 out of 2, this is the gray zone where you have to use other tools. I'll keep repeat this because if you go out of this room memorizing this diagram, we win. So if the function is depressed or the patient is known, a HFpEF, or known to have a diastolic dysfunction, here we start with the mitral inflow, not the tissue Doppler velocity of the annulus. So we see the EE ratio. If the EE ratio is less than 0.8 and the E amplitude is less than 50 centimeters per second, this is a normal filling pressure. If the EA ratio is more than 2, and you have to confirm it by Valsalva maneuver. How to do Valsalva maneuver? You are putting the probe, you ask the patient to take a deep breath, hold it, here the picture disappeared because air is in. Get it out, and you measure. Remember, the picture will disappear because the lungs will inflate when he take a deep breath. Then he take it out, then he comes, then you catch it. So you keep your hand fixed. So here we have the same 3 criteria we talked about: EE prime ratio, TR velocity, LA volume index, but we divide patients by the EA ratio, not E prime. EA ratio of the mitral inflow at the tips of the mitral valve by the pulse Doppler. So we have normal, we have grade 3 abnormal, and that grade 3 you have to differentiate by Valsalva maneuver, whether it is reversible or irreversible. This is the restrictive. And comes the whole game is the in-between. You have the 3 criteria. When you have 2 criteria are negative, then you are talking about normal. If 2 are positive, you move to grade 2 because it is between 0.8 and 2. And if 1 positive, 1 negative, this is indeterminate. And indeterminate, we have to use other tools. Let's see this one. This is a patient of ATTR cardiac amyloid. His EA ratio is 6, more than 3. We have, of course, cherry on top of preserved contractility in the apex, but the TR is 4. And the E prime is 4. This is less than 7. And EE prime ratio is 30. So we have EE ratio of 6. We have 4 centimeters square per second for the EE prime ratio, EE prime velocity. We have EE ratio is 30. TR velocity more than 2.8. So we have all the 4. This is grade 3. What's left is to see that mitral and do Valsalva. If it is the same or the A gets higher. If the A gets higher, this is grade 3 reversible. If the A still small, this is grade 3 irreversible. Also, we have always to look to the mitral inflow carefully with the pulsed Doppler, and we see if you have a dip in the middle. This is called L wave. It is delayed relaxation, and it is impending failure. It is impending high filling pressure. So that L in the middle between E and A is very important to tell you that the filling pressure might be high. So we look to another patient of 67-year-old with ischemic cardiomyopathy, heart failure, grade 1 diastolic dysfunction, normal filling. This patient has an E ratio of 0.5, E of 45, A of 90. So we have E less than 50, and the ratio is less than 0.8. So this is a normal filling pressure if we use our tool. Then this patient 2 months before had a different A amplitude, E amplitude, EE prime ratio of 30. So, and TR of 3 meters. So this patient, 2 months before, he was in heart failure. So this filling pressure is dynamic, is changing, is not fixed. You don't say, you tag me, you have a high filling pressure. You give me Lasix, it will come down. So it's a way to monitor your patient, and you can do it today, and after 2 days you repeat, you find filling pressures are coming down, he is getting well with your medication, you might start IV, stop the IV Lasix, institute disease-modifying agents. So how you integrate the echo and filling pressure in your treatment, daily treatment. This is just a curve to show you that survival is best when the E ratio is between 0.6 and 0.8, and after that, mortality increase because high filling pressure, heart failure, so mortality of heart failure. So the same patient was in failure. We used the same tool to decide that he was grade 2 diastolic dysfunction and became grade 1 after 2 months. So difficult situation to assess the diastolic function when you have two normal, two abnormal, when you are in the middle, like HCM, LBB, mitral annular calcification, atrial fibrillation. And another supportive tools that we might not have time for it is the pulmonary vein analysis, Valsalva maneuver we talked about, measuring the isovolumetric relaxation time we talked about, and strain. The most evolving time now is the strain or the left atrial reservoir strain. We know the function of the atrium is reservoir, conduit, contractility, 3 stages. Measuring the left atrial reservoir strain is now emerging as the tool to determine the filling pressure when you are in doubt. And of course, when you have the capability, not all echo labs have left atrial strain, but if you have the chance, then you should practice it, especially when you have doubt. Pulmonary veins, we know it has the A reverse, the systolic component, which is 2 components and sometimes 1, and the diastolic component. By time the systolic component comes down and filling pressure rises up and the A reverse increase and D increase. By the time S become flat, D is higher, and in grade 3, the A reverse will be longer. So this is how the progression through stages 1 to 3. Also, when we look to the filling pressure, you might have the looks of grade 1 or 2. It might look normal, but when you measure the A reverse duration, if it is 30 milliseconds or more in duration, more than the A of the mitral, this is definitely a high filling pressure, and this is plotted in this study versus in diastolic pressure. So if the duration is more than 30 milliseconds, you have a high filling pressure. Another patient, a 67-year-old woman with hypertension and shortness of breath. Her left atrial volume index is 54, TR is 2.8 meters per second. Her E is 90, her A is 40, so her EA ratio is 2. This is high. Her EE prime ratio here calculated to be 12 and 13, so this is normal. TR is less than 2.8, but the atrium is big, so we have 2 out of 2. Here, you cannot draw a conclusion, oh, this is normal, abnormal. This is in the gray zone, where you have to use the other 4 tools. So, this patient is indeterminate. Use other tools, use left atrial reservoir strain, or if the patient is sick and you have the capability of a CAS, then you should do a right-sided CAS. Also, this patient, we did some maneuver, is the Valsalva. When we did the Valsalva, the A got longer and the A came down, so the EA ratio of 2.3 became 1. So this patient is not really having a high filling pressure. That's why there is variability, and it needs training. You should practice more so you develop the experience. This is high filling pressure, and this is deceiving. I will do a maneuver. One of the maneuvers is Valsalva. So in conclusion, in this study where they studied symptomatic patients with Hossam, they said that precise characterization of LV filling pressure in an individual patient cannot be determined with the use of these non-invasive. They used all the 9, the 4 and 4, and they could not reach. In such a case, the gold standard is right-sided cardiac CAS. Or you do Valsalva maneuver, or you do left atrial reservoir strain. I believe it is rising, and it will decrease more the number of CAS studies. So in the hypertrophic cardiomyopathy, E velocity is reduced in almost all patients. The EE prime ratio predicts clinical outcome, and other parameters should be put in mind. EE prime ratio more than 15, LA volume index more than 24, TR velocity more than 2.8, and the duration of the A reverse is more than the A of the mitral by 30 milliseconds. You might be feeling curiosity about what I'm saying, but the more you practice it, the more it will be fluent with you. So if you have 2 or more positive or 2 or more negatives, push you to the high filling pressure or not. So that patient has 2 EE prime ratio. One of them is 40 because the medial is E prime is 2, and here the medium E prime is 5. So when the 80 is divided by 5, this is 15, which by the 2 is 40. So which one to believe? Does he have a high filling pressure or not? Another one, the previous one was indeterminate, but this one is a young one with Hossam. We need to know which grade is he. His EE ratio is 2.3, so if we just get it blindly, AE ratio is 2.3, I have done the pulsed Doppler on the mitral, this patient has a high filling pressure, and this is very serious because he's only 23. And you know Hossam will have a supersystolic function. So if you say filling pressure is high, you are pushing him to a very high risk category. So what to do? We can see the medial E prime is 8, the lateral is 10. So the ratio, EA prime ratio is 9, EA prime ratio is 7. And we said earlier that EA ratio in a good systolic function should not be the first one, it should be the E velocity, E prime velocity. So in this case, his filling pressure is normal. Also, when you do the Valsalva maneuver and you find that the AA ratio, that was just abnormal, the only one, and it become more or less proving that it is a normal filling pressure. So in Hossam, you look to the EA prime ratio, not the AA ratio. You look to the BMP, and both are related to if they are higher to high event rate and if they are not higher to a lower event rate. At this point, I'll stop. My colleagues will continue, and we will meet in the clinical session.